tract infections separated into infections of the lower urinary tract that involve the bladder, the urine bladder, and urethra, and those of the upper tract that involve the kidney, renal pelvis, and ureters. So, involve lower part of the urinary tract and upper part of the urinary tract. Infections of the upper tract are designed like a pyelonephritis and combined in the term of pyelonephritis in pathology of the pyelonephritis. And underlying conditions include abdominal anatomy, urologic dysfunction, the presence of an indwelling catheter, or isolation of the multi-resistant organism. If you look to this picture, we're returning to the scheme, only scheme of the normal anatomy. Lower part included ureter, bladder, urine bladder, and upper part ureters, kidney, and renal, and exactly so in ureter, about colonization. Just a minute, I'll find the student with switch on microphone. So about colonization. Colonization in urethra, pathogen colonize the periuteral area and extends through the urethra upwards toward the bladder in case of some disturbing. Uroepithelium penetration in the urine bladder, fimbrial of bladder epithelial cells attachment and leading to penetration microorganism in the wall of the urine bladder. Following penetration, bacteria continue to multiply, to replicate, and can lead in may form biofilms. Ascension in the zone of ureters. Once sufficient bacterial colonization occurs, and bacteria may ascend on the ureter towards the kidney, and it ascending way of infection. Fimbria may aid in the ascension process, and bacterial toxins also take a role by inhibiting peristalsis and reducing the flow of urine. How bacterial toxin leading to some disturbing the normal peristalsis of ureters due to inflammation, swallowing of the wall of ureters, leading surely not for normally peristaltic, and it's leading to urostasis, and urostasis in this turn also can be a reason of multiplying of pathogenic bacteria. Next layer, it's a kidney or pyelonephritis. Infection of the renal parenchyma causes an inflammatory response called pyelonephritis. And while infection of the renal parenchyma is usually the result of bacterial ascension, it could also occur from hematogenous spread. So infection can go into the kidney by hematogenous way, like we discussed with you in case of pneumonia, absolutely the similar. Hematogenous traveling in the central bloodstream, pathogenic bacterial, and ascending with receptors in the kidney. And all these problems through colonization, uroepithelium penetration and development inflammation in urine bladder, extension through the pyelonephritis can lead into acute kidney injury. Acute kidney injury in the inflammatory cascades continue. Surely it depends from the duration of these cascades, depend from the duration of inflammation. Tubular obstructions and damage occur and lead into interstitial edema. This may lead to interstitial nephritis and can lead in turn causing to acute kidney injury. Acute kidney injury like renal failure, but it's acute problem. It's not like it's a kidney failure, but it's acute kidney injury like a term. So next, our scheme of pathogenesis. Mixed urinary incontinence leading to urinary leakage accompanied by both urgency and increasing in intra-abdominal pressure. This factor, like increasing in intra-abdominal pressure, also play a role in the pathogenesis of urinary infections. So urinary leakage, and we can divide it in by two ways: urgency urinary incontinence and stress urinary incontinence. About urgency urinary incontinence, like acute problem leading to urinary leakage preceded by sudden stroke urge to work. In this case, overflow incontinence leading to overfilling of the bladder from obstructions. From bladder outlet obstructions, it can be obstruction of pressure by a tumor, it can be obstruction by a stone, it can be obstruction by hyperplased prostatic gland, or it can be obstruction by urethral or bladder neck structure. Any type of structure or any type of obstruction, inner side and external side obstruction. Next problem, detrusor overactivity. It can be overactive bladder, it can be idiopathic problem, or it can be by central nervous system lesion, for example, neurogenic problem with the innervation of urine bladder. Inflammation or infection in case of cystitis, in case of urinary tract infections, and diabetes mellitus, like a predisposing factor for inflammation. Next problem, decreasing in the bladder wall compliance. Progressive increasing in large in intravesical pressure during bladder fillings, passing urine from the bladder. All these problems leading to failure to store, failure to void, and urodynamic studies. From another side, it's pathogenesis of stress urinary incontinence. Like a sign, it's episodic involuntary urinary leakage with sudden increasing in intra-abdominal pressure, which leading to urethral hypermobility, intrinsic sphincter deficiency, and or a poorly compting urethra. All problems and all view problems with the mobility of the wall of urethra and gallbladder. It's leading to decrease in pelvic floor muscles and ligament stretching, causing decreasing tone of vesico-urethral sphincter unit and decreasing to urethral stretch and associated striated and smooth muscles, or it can be iatrogenic like a result of operation on the organ of pelvises. All this problem leading to failure to void, weak stream, plus minus dribbling, intermittent straining, increasing in post-void residual volume, if a complication of urinary retention, and obstruction visible on cystoscopy during cystoscopy. Failure to store, frequency, urgency, nocturia, dysuria, all these problems which we discussed with the previous lecture. If stress urinary incontinence or urinary tract infection not caused by obstruction. Urodynamic studies. Decreasing of stress urinary incontinence, decreasing urethral closure pressure with increasing intra-abdominal pressure and bladder volume and urinary leakage. Or urgency urinary incontinence, involuntary detrusor contraction and or detrusor sphincter dysenergy. So by these clinical signs, we can find with you the type of urodynamics. And all this leading to incontinence and decreasing quality of life and urinary tract infection. It's a general scheme with the general mechanism of development of urinary tract infections. About the etiology of urinary tract infections, Microorganisms can reach the urinary tract by hematogenous or lymphatic spread, as we discussed with you some later, but there is evident clinical and experimental evidence and researching that showing that the ascent of microorganisms from the urethra is the most common pathway that leads to urinary tract infection, and especially it will be types of organisms of enteric regions like Escherichia coli and other enterobacterians group. In this tone, hematogenous infection in the urinary tract is restricted to a few relatively uncommon microorganisms, such as Staphylococcus aureus, Candida, Salmonella, and Mycobacterium tuberculosis, which cause primary infection elsewhere in the body, and Candida albicans readily caused a clinical urinary tract infection via the hematogenous route, but this is also an infrequent cause of an ascending infection if an end-wearing catheter is present or following antibiotic therapy. So more often cause and more common cause of urinary tract infection, it's ascending way of infection from the lower part of the urinary tract, but it can be and it depends from the total immune status of the organism, like a hematogenous and lymphatic spread, especially in the such types of bacteria like Staphylococcus, Candida, Salmonella, and Mycobacteria that primary had some another search of infection and can lead in by the central bloodstream to the kidney. About classification of urinary tract infections, we can separate it by the anatomical level of infections. Urethra, and we can call it urethritis, acute or chronic. Urinary bladder, and we can call it cystitis. Kidney, and we will speak about pyelonephritis, and bloodstream, totally urinary sepsis. Classification of risk factors, which can be a host factor of urinary tract infections. And look at this classification, we can separate it with you like O, R, E, N, U, and C group of factors. It's a special classification for urinary tract infections, which preserved in the guidelines. And look, in the first line, it's category of the risk factor. In another line, it's examples of risk factors. For example, O, non-known or associated risk factors. For example, healthy premenopausal woman. Are recurrent urinary tract infection risk factors, but not risk of several outcomes for this infection. Sexual behavior and contraceptive devices, hormonal deficiency in postmenopause, deficiency of estrogen in postmenopausal women, secretory type of certain blood groups, and controlled diabetes mellitus. Cause level of the glucose in the biochemical blood also and increasing and not well controlled diabetes mellitus like working like the host factors. E, extra urogenital risk factors with the risk of more severe outcomes of this infection. Pregnancy, male gender, badly controlled diabetes mellitus, relevant immunosuppressions, connective tissue disease or connective tissue disorders like scleroderma, and prematurity or newborn. And we can explain like a nephropathic disease with risk of more severe outcomes of this infection. Included relevant renal insufficiency or renal failure or chronic kidney disease and polycystic nephropathy. And in the background, it's already disturbing of the functional status of the renal. U, we can translate like urological risk factors with risk of more severe outcomes, which can be resolved during therapy. And in this group, we included ureteral obstruction by the stones, by the stricture, by the tumor from outside, transient short-term urinary tract catheter and staining of catheter in the urethra in case of emergency room, in case of reanimation. Also, it's a host factor. Asymptomatic bacteriuria due to daily bacteriuria analysis, controlled neurogenic bladder dysfunction, and urological surgery or surgery intervention on the organ of pelvis and urological tract. And C, we can translate like a permanent urinary catheter and non-resolvable urological risk factors with a risk of more severe outcomes. Long-term urinary tract catheter treatment, non-resolvable urinary obstruction, and badly controlled neurogenic bladder. This last classification, with classification domain of host factors and examples of these risk factors. Another type of classification, it's additive parameters of urinary tract infection classification and severity assessment. In fact, it's the similar information from the two previous classification. Look, clinical presentation by the anatomical layer, by the anatomical structure, urethritis, cystitis, pyelonephritis, urosepsis, and male genital glands. Grade of severity, low cystitis, pyelonephritis, moderate, for example, pyelonephritis severe and established the severity, urogenital sepsis, urogenital sepsis with organ dysfunction, and urogenic sepsis with multi-organ failure. Risk factors from this classification, which we discussed with you, O, R, E, and O, C. And pathogens, specialty or susceptibility grade, susceptible, reduced susceptible, and multi-resistance. Depends from the sensitivity to antibacterial drugs. Surely by this gradity, we can assess the severity and the severe and the way for our outcomes of our patient. Returning to pyelonephritis. Acute or uncomplicated urinary tract infections in adults include sporadic or recurrent community-acquired episodes of acute cystitis and acute pyelonephritis. Surely from the urinary tract infection, acute cystitis and acute pyelonephritis is the most common problem in the population. In otherwise healthy individuals, comprising the host risk factors O and R from the group O and R, and partially E according by this classification which we discussed with you on the table 1. These urinary tract infections are seen mostly in otherwise healthy women without relevant structural and functional abnormalities within the urinary tract, kidney disease, or comorbidity that could lead to more serious outcomes and therefore require addition. Pyelonephritis, it's a non-specific infection and inflammatory process which is characterized by a simultaneous or sequential damage to the calyx pelvic system and renal parenchyma, mainly surely damage of intestinal tissue. Chronic pyelonephritis in this term, it's a long-term infection and inflammatory process in the wall of the pelvis, cusps, in the stroma and parenchyma of the kidney, and chronic pyelonephritis can be outcomes by acute pyelonephritis, but in most cases it occurs in a relatively calm current process. So, pyelonephritis, acute pyelonephritis, sudden development of kidney injection, chronic pyelonephritis, long-standing infection that does not clear and can result in kidney scarring, occurs only in patients with major anatomic abnormalities. Need a substrate. We need a substrate for chronic inflammation process. Xanthogranulomatosis pyelonephritis, like a chronic pyelonephritis that occur in obstruction due to infected renal stones. Affected patients usually have a massive destruction of the kidney and confused with the renal malignancy. And recurrent pyelonephritis, more than 2 infections in 6 months, or more than 3 infections in 1 year. And you can speak about recurrent pyelonephritis. So classification of pyelonephritis. In terms of localization, the process can be one or two way, one or two side, common on both sides. There are phases of chronic inflammation process of kidney, active inflammation and period of active inflammation, latent inflammation and remission or clinical recovering. Primary pyelonephritis, development in an intact kidney without developmental abnormalities and without diagnosed dilation of the urodynamics of the upper urinary tract. And secondary pyelonephritis, which occurs against on the base of backgrounds of disease that disrupt the passage of the urine. And this disturbing of the urination, this disturbing of urodynamic can lead into secondary development inflammation process, in which cases we can speak with you about secondary pyelonephritis. Abnormalities in the development of the kidney and urinary tract, urolithiasis disease, structures of the ureter of various etiology, hormones disease or retroperitoneal fibrosis, Vesica uretral reflux and reflux nephropathy, adenoma and sclerosis of the prostate gland, sclerosis of the bladder neck, which leading to stricture, neurogenic bladder, especially hypotonic type, decreasing normal mobility, normal activities of the wall of the urine bladder, kidney cysts and kidney tumors, neoplasm of the urinary tract, and malignant tumor in the genital organs. On the background of this disease, all disease can lead into developing secondary inflammation in the renal pelvis. And primary pyelonephritis on the base of absolutely clear and intact kidney. About the stages of acute pyelonephritis are also separated. Serous inflammation and the stage of serous inflammation, purulent inflammation, apostomatosis pyelonephritis, kidney carbuncle, and kidney abscess, like a total stage. About epidemiology, almost half of all women will express at least one episode of urinary tract infection during their life. Nearly 1 in 3 women will have had at least one episode of urinary tract by the age of 24 years. Only small numbers between 15 and 50 years old men suffer from acute uncomplicated cystitis, and all urinary tract infection, including cystitis and pyelonephritis, occurs more frequently in patients with diabetes mellitus, which may represent it in case of independent risk factors for inflammation in any region, not only inflammation of kidney injury. It's, however, difficult to determine the impact of renal insufficiency on the epidemiology of urinary tract infection because of the wide variety of underlying disease. The place of immunosuppression therapy foreseen the development of urinary tract infection remains also unresolved. For example, in male patient with HIV infection, a close relationship between CD4 counts and the risk of bacteriuria was found, particularly in a patient with count counts of the cells will be less than 200 in millimeters. About 40% of those with bacteriuria, however, were symptomatic, and there is no evidence to the treatment of antibacterial drugs, and this group leads to improved outcomes. And the spectrum of etiological agents is similar in uncomplicated upper and lower urinary tract infections. With Escherichia coli, the causative pathogen in 70–95% of cases, Staphylococcus saprophyticus in 5 and 10%, and occasionally other road and group of enterobacteriaceae such as Proteus mirabilis and Klebsiella are isolated. In this table, you can find predisposing risk factors for development pyelonephritis. And also we separated our patients for two groups, young and premenopausal women and postmenopausal and elderly women. About young and premenopausal women and sexual intercourse, use of spermicides during sexual contact, a new sexual partner, and sometimes the first episode of pyelonephritis in early women associated with the first sexual contact, a mother with a history of urinary tract infection and history of urinary tract infection during childhood. It shows you that there is some anatomical structure, some anatomical problem, some anatomical disturbance which are leading to aggravation inflammation in the lower part of urinary tract and leading by a standing way to pyelonephritis. Young and premenopausal woman, postmenopausal and elderly woman, which host factors, history of urinary tract infection before menopause, urinary incontinence, stain of the urine in the gallbladder, central nervous problem with innervation gallbladder, stain in the urine leading to a problem with infection. Atrophic vaginitis due to estrogen deficiency on the phase of postmenopausal. Cystocele, it's like a tumor, it's a cyst in intraperitoneal space, which including some liquid. And this cyst including liquid stain and leading to some pressure to urine bladder, to ureter, and leading to disturbing normal anatomical structure of pathogens and can be a reason of pyelonephritis. Increased post-void urine volume, blood group antigen secretory status, urine catheterization and functional status of the urinary tract, and functional status deritation in elderly institutionalized women. So some different host factors in these two groups of patients. So in this picture you can find the pathogenesis of pyelonephritis. And look, primary predisposing factors which we discussed with you. Immunocompromised by any connective tissue disorder, by background disease. Diabetes mellitus, elderly, female, short ureter like host factors. Stagnant urine, anatomical variant, obstruction, urogenic bladder, urinary reflux, pregnancy. Indwelling urinary catheter, stent, and nephrostome tube. It's already predisposing factors, not all, but the main which leading to that the renal can be infected. Leading to impairment of the body usual defense system, stagnant urine in the urinary tract, iatrogenic growth surface allow bacterial accumulation. It's leading to bacterial proliferation and bacterial multiplying. Allow urinary tract infection. Bacteria ascend ureters from the lower tract as a complication of asymptomatic bacteriuria or cystitis go by the ascending way to the kidney, leading to bacteria uniquely low then to adhere to renal parenchyma, leading to bacterial proliferation. Primary infection of the parenchyma by a hematogenic or lymphogenic spread, direct inoculation after the taken analysis by the biopsy in case of in-touch established the type of glomerulonephritis, and infections emboli from endocarditis in case of septic, for example, leading to bacterial multiplying. So, All these problems leading to upper urinary tract infections or phylonephritis. Infection of urinary tract above the urine bladder by capable bacteria colonizing epithelium and causing to all clinical symptoms of kidney problem. So, separated for four problems. Bacterial colony irritates urinary epithelium, leading to such clinical symptom like dysuria. In the same time, simultaneous of urinary reflux, leading to urgency, it's like a symptomatic sensation of needed to urinate quickly or independent incontinence. Frequency, sensation of repetitive need to urinate. Clinical picture, clinical picture. Next, pathogens use enzymes to reduce nitrate to nitrite, and it's leading to some urine findings. Increasing colony count more than 10 and 7 degree per liter, increase in white blood cells in the blood analysis and like a sign of general inflammation, positive bacterial culture, positive nitrates, leukocytes esterase in the urine analysis, turbid urine, and plus minus can present red blood cells in the urine analysis. It depends from the type of inflammation. Inflammatory response initiated, leading to white blood cells once it release enzymes, leading to urine findings. Inflammatory response initiated, leading to inflammation of renal parenchyma and capsule, leading to development such clinical symptoms like a flank pain and costovertebral angle tenderness, and leading to cytokines released systematically effects, leading to general effect like fever, malaise, nausea, vomiting like general signs of inflammation, and leading to increase in white blood cells on clinical blood tests more than normally average, or normally range from 4 till 9. Also associated with general infections. So in the urine, increase in colony count in case of analysis of bacteriuria, increase in white blood cells or leukocytes in the urine analysis, positive bacterial culture, positive nitrates, positive leukocytes esterase, positive fall or turbid urine, and positive can be hematuria, and hematuria is presence of red blood cells in the urine analysis. From the side of the blood, all signs of general inflammation. Leukocytosis with shifting to the young form, positive ESR, positive C-reactive protein in case of urine sepsis. About clinical symptoms, flank pain, which we discussed with you already, nausea and vomiting, fever, more than 38 degree, and we discussed it with you already why hectic type of temperature curves associated with infection of the kidney, costovertebral angle tenderness, and it can occur in the absence of symptoms. It can be symptoms that are suggestive of cystitis, such as dysuria, urinary bladder frequency and urgency, suprapubic pain, and hematuria, and really changing the color of the urine to the red color. May be also present. In some cases, the presentation may mimic pelvic inflammatory disease, some disturbing really inside the pelvic region. Most men with febrile urinary tract infection had a concomitant infection of the prostate as measured by transient increase of PCA, like tests of function of the prostate volume, and in case of increasing volume of the prostate by the ultrasound. Thus, urological evaluation should be carried out routinely in men with febrile urinary tract infection, pyelonephritis, or recurrent urinary tract infection, or whenever a complication factor is suspected. In patients with diabetes mellitus with acute pyelonephritis, metabolic abnormalities can present, included hypo and hyperglycemia, hyperosmolar dehydration, tilde ketoacidosis, tilde acetic ketoacidotic coma, need to closely be followed. Diabetic patient may also develop progression of renal parenchymal infection and sometimes caused by gas-forming organism. With a high mortality in case of emphysematosis pyelonephritis, characterized histologically by acute pyogenic infiltration with microabscession and in the development of acute renal failure. Diabetes mellitus is a host factor not practically for all inflammation disorders cause diabetes mellitus and presents increase in large level of the glucose in the biochemical analysis. It's a substrate, it's a nutrition for bacteria, and more higher glucosage in the biochemical analysis, just as simple, it's only nutrition for replication of all microorganisms. The risk of chronic renal disease and renal insufficiency caused by pyelonephritis is low, isolated pyelonephritis very low. Underlying lesions including vesico-uretral reflux, analgesis abuse, nephrolithiasis, and obstruction of the urinary tract have to be observed, and however, acute bacterial infection, including pyelonephritis, can dramatically influence the progression of the chronic renal disease and why there is a chronic renal failure can after the severity of an infection. It's a good picture which shows ascending way of infection of the kidney. Look about clinical picture. 2F and DUF. Flank pain, which we discussed, fever and chills, the symptom of dysuria, the symptom of urgency, urination, and frequency. All these points, all the signs are significantly associated with pyelonephritis, and you can look to this picture. It can be ascending way, but it also can be by hematogenous and lymphatic lymph spreading way. Descending infection by the hematogenous in case of septicemia, in case of infectious endocarditis, in case of sepsis. And ascending infection associated with Escherichia coli due to host factors which we discussed with you, more short urethra, more wide urethra in a woman, postmenopausal woman, which leading to decreasing level of estrogen, which helps to the wall of urogenital tract and taking the normal urodynamics. All these problems are associated with ascending infection or ascending way of infection of the kidney. Escherichia coli and the route of Enterobacter go into the up to infected the kidney. And in this case, we can spoke with you about acute pyelonephritis, inflammation of renal pelvis, and kidney inflammation. Acute pyelonephritis can be and can lead into development chronic pyelonephritis and recurrent pyelonephritis. But sometimes we can speak with you about chronic pyelonephritis and exacerbation of this pathology. But in fact, this exacerbation, it will be acute pyelonephritis. What risk factors? Female, short urethra, urethra near anus, pregnancy like a host factors cause pregnancy leading to increasing intra-abdominal pressure, pressing to ureters and leading to stasis of urine, and menopause, decreasing of estrogen. urinary stasis, hyperplasia of prostate gland, stones, cancer, and pressing obstruction from outside. Next, congenital spinal injury, diabetes, about innervation, volume of urine, and instrumentation host factor or iatrogenic damaging. It can be cystoscopy. It's a visual, it's a laparoscopic examination of the volume of the urine bladder, and the catheterization of the urine bladder also its host factor, which can lead into. About analysis of urine, look, pyuria that told us about presence white blood cells in the urine analysis, and bacteriuria positive culture. About physical examination patient with urinary tract infection. On physical examination, recommended that addition to pain on palpation in the kidney area, as we discussed with you in previous lecture about palpation in the zone of projection by manual palpation. Usually 4 moments of the palpation, pain during palpation of the kidney, positive symptom of Pasternetsky from the affected size, that a tapping by the back side of your hand from the back side and the projection of the kidney, the presence of polyuria and pelagiuria and emergency of urination, measurement of blood pressure, because it can be associated with secondary arterial hypertension. Body temperature is recommended also. Laboratory diagnostics. Surely during physical examination in case of urinary urogenital sepsis, we will speak with you about general signs of inflammation, change in the consciousness, decreasing of BP, like a sign of shock, and so on. It's only routine physical examination patient with acute or chronic pyelonephritis. Laboratory diagnostics. Recommended to carry out a standard algorithm examination, which including, and we'll start from general urine analysis, bacteriological analysis of urine to come from the culture, general blood analysis, and blood chemistry analysis. A laboratory study of urine reveals leukocyturia or presence of white blood cells in women more than 5. In examples, in men more than 3. In examples, in most cases, neutrophilic genesis, inflammation, practically absolutely the same, and presence bacteriuria. Possible proteinuria, but small volume of proteinuria, the presence of proteins in the urine analysis up to 1 gram per day, and really it will be not real proteinuria, it will be proteinuria which associated with presence white blood cells and red blood cells in the urine analysis, because it's also protein structure. Microhematuria, it can be due to squamosity of epithelium in case of inflammation. During pyelonephritis, we can find some red blood cells in acute stage of pyelonephritis. Hypostenuria, and it means that decreasing of the density of the urine, and alkaline urine reaction, which significantly for inflammation. Bacteriological analysis of urine is shown to all patients for identification of the causative agent, the nature of this inflammation of the disease, and the appointment of an adequate antibacterial therapy. Surely bacteriological analysis of urine with assess sensitivity to antibacterial drugs. When quantifying of degree of bacteriuria, a level more than 10⁴ degree in milliliter is considered significant, because if bacteriuria will be less than this count, for example, level of 10⁵ degree, it's caused like asymptomatic bacteriuria, and we can not treat such patient. Excluded two categories: pregnant woman and woman who will take implants of surgery intervention in the pelvitis or urogenital tract. In non-standard cases with polyuria or immunosuppressions, a low degree of bacteriuria may be clinically significant. In the general blood tests, recommended to pay attention to hematological signs of inflammation, as you know, neutrophilic leukocytosis, we're shifting to the left side, increased ESR, and increase CRP. In the chemical blood tests, we need to assess with you general indicators like bilirubin, like urea, like creatinine, which show us to clarify the functional state of the liver and kidney and to assess the level of involvement of organs to this inflammation process. It's recommended to perform the red blood tests at a minimum suspicion of chronic renal failure for assess the real glomerular filtration rate. And the red blood test, it's a ratio between the creatinine of blood and creatinine of urine, which show us real glomerular filtration rate, because we can count it by formula. Chronic kidney disease epidemiology by the formula, which we discussed with you. And also we can continue with red blood test, which show us real. Next laboratory science, the analysis for daily proteinuria and qualitative studies of excreted proteins are recommended to be performed in controversial cases for differential diagnosis with primary glomerular renal ratio or nephrotic syndrome. With severe arterial hypertension and problems in the selection of anti-hypertensive therapy, and in case of alternative diagnosis, in case of catching alternative diagnosis, recommended to perform blood tests for the serum of renin, angiotensin, and aldosterone to assess the activity of renin, angiotensin, and aldosterone system. No, it's an ordinary list of laboratory diagnostic patients with pyelonephritis. Next point, instrumental diagnostic of pyelonephritis. It's recommended to perform ultrasound of the urinary system, which allows to diagnose edema of the parenchyma with exacerbation, as well as a decrease in the size of the kidney, its deformation, increased homogeneity, increased density of the parenchyma, and signs of nephrosclerosis with long-term current pyelonephritis outside exacerbation. So on the phase of exacerbation, it will be swollen, it will be edema of the kidney from the side, affected side. But during the time in patient with chronic pyelonephritis, you can diagnose decrease in the normal size of the kidney from the both sides or from the one side, more affected side, and find the signs of nephrosclerosis. Just a minute, I'm sorry. Natalia Alexandrovna, да. So signs of nephrosclerosis with long-term current pyelonephritis outside exacerbation. So, and you can find there the picture of ultrasound. Expansion of the calyx pelvic system indicates a dilation of the passage of the urine. And in addition, we can find with you in Doppler region ultrasound that help us to visualize the degree of blood flow disturbance and to find some problem with the stenosis of the kidney artery and to gradate it the primary or secondary arterial hypertension. And there you can find the difference in the size. Look, difference in the size of the kidney. It's a right kidney and it's a left kidney. Look, some pneuma and its emphysematosic type of pyelonephritis of left kidney, increasing of the size of the pelvis, increasing contour. By contour, not groove. Normally contour, but it's edema, it's a swelling, it's urostesis. Next type of instrumental diagnostics, excretory urography, early radiological sign of pyelonephritis by this method will be a decrease in the tone of the upper urinary tract, decrease in the tone of ureters, flattening and redness of the corners of the fornix, and narrowing and the elongation of the cusps and damaging of the structure of the cups of the kidney. In the later stage, there is a sharp deformation of the cups, their rapprochement, pilorenal refluxes, and pilectasis. Also, by the X-ray diagnostics or excretion urinography, characterized by Hodgson symptoms and a decrease in the renal cortical index, detection on excretory urograms of a decrease in the thickness of the renal parenchyma in the poles in comparison with the thickness in the middle segment. Decreasing of the thickness of the renal of the cortical segment. Normally, the thickness of the parenchyma and the distance, it's the distance between from the outer contour of the kidney to the papilla of the pyramids, in 2.5 centimeter in the middle segment of the kidney and 3 and 4 centimeter at the poles. So reducing this ratio or renal cortical index, it's also a sign of chronic inflammation or Hodgson symptoms. And there you can assess excretory urography. It's a positive X-ray method with using intravenous contrast, and this contrasts filtrates with the blood through the urine, and you can contrastate it and visualize the form of the kidney, the form of the pelvis, the time of evacuation of the urine from pelvis through ureter to the bladder, the time of evacuation of the urine from the bladder to outside, and can confirm the problems with the innervation of gallbladder. It's excretory urography. There, it's CT scan. Look, deformity of the kidney, difference in the size of the kidney. In the patient with continues to have fever after 72 hours from the onset additional examination, such as spiral computer tomography or excretory urography or nephroscintigraphy, are recommended to visualize, more concretize the problems. Radioisotope research methods are recommended to be performed to resolve the issue of the symmetry of nephropathy and assess the functional state of the kidney. And in fact, pyelonephritis usually it's associated with one side affected. It can be two sides affected, but usually more affected one kidney. And in case of alternative diagnosis like glomerulonephritis, chronic kidney disease on the base of diabetes mellitus, on the base of connective tissue disorders, usually it's absolutely both sides affection. Next, to detect vesicular-ureteral reflux and other changes in the lower urinary tract problems, recommended to perform local cysto-retrography, visualization of condition of the urine bladder, and or radioisotope renography with excretion or with contrast. CT scan and MRI recommended to be performed to diagnose disease that can be provoked, which can be leading to pyelonephritis. For example, to confirm diagnosis of urodissection, to confirm the presence of stones, CT scan with a contrast, with the blood contrast. To confirm diagnosis tumors and abnormalities of the kidney and urinary tract, usually recommended CT scan with a contrast MRI. But look, you need to assess the glomerular filtration rate, the speed of glomerular filtration, and assess the advantages from the contrast cause. Contrast and intravenous type of contrast, it's already damaging substrate for the kidney and nephropathic. So the last type and the last way of instrumental diagnostics, it's a kidney biopsy, recommended to make and to take a differential diagnosis with other diffuse lesion of the renal tissue, and especially when deciding on the need for immunosuppressive therapy in the case of alternative diagnosis with glomerular nephritis. Surely routine pyelonephritis normally not recommended, so invasive and damaging method like a biopsy of the kidney. But on the other side, glomerulonephritis, absolutely a gold standard. It's kidney biopsy with histological examination. So that's all for today.